Our organization recognizes that it was created by the voices of Gulf War veterans. In 1996, when the Department of Defense realized that it didn't have all the answers for Gulf War veterans, it established the Office of the Special Assistant to get those answers. Today, we continue our efforts to help Gulf War veterans. You see our helpline, the 1-800 line. We continue to get calls from Gulf War veterans. I think a recent example that I'm very proud of, our folks working with the VA, when a veteran called us and said that 2 years after the Gulf War, he started experiencing problems, was seen in the VA, received a diagnosis, but got no benefits. For 6 years, he worked this issue. He'd written to his congressman, the president, had really not received any help. He gave us a call. It took us about a month working with different people in the VBA and VHA, and a decision was made to not only find him 100% disabled, but to find it service-connected and to give him 6 years of retroactive pay. You know, that's a success story. We feel very proud about that, and we continue to want to work with Gulf War veterans when we can help work them through that morass of red tape that certainly is our government. GulfLink is our website. We will continue to have information there about Gulf War and to update it as new information becomes available. Each final report that we do and the investigations that have been done will appear on GulfLink, and it'll also be registered by the Library of Congress to make sure that there's a permanent record of that contribution. Deployment Link is our newest website, which is trying to really attune not only those service members who are about to deploy, but their family members of what is involved in protecting their health and what they need to understand and recognize are the efforts the Department of Defense is making to protect health. As you heard from Vicki Booth yesterday from Health and Human Services, that MedSearch is going to be added to GulfLink, and that we expect to be up early part of June. This is essentially trying to put into one place all the federally funded research on Gulf War veterans and Gulf War veterans' illnesses, so it can be looked at not only by the Gulf War veterans and their families, but by researchers who can say where are the gaps from their perspective of science that we can address. Next slide. Again, I want to emphasize the Department of Defense recognizes that Gulf War veterans are ill. I had an opportunity to brief the Deputy Secretary of Defense shortly after he came into office and highlighted here that symptoms in Gulf War veterans occur at 2 to 3 times the rate that they occur in people who did not deploy. We heard this repeated several times by different researchers. This is a unique issue that we need to take seriously. To recognize it is not necessarily to understand it, and that's where the next evolution of research needs to go. Syndromes, as an individual physician, I think that we get lost in argumentative words over whether there's a syndrome or not. Gulf War veterans are sick. We need to move forward from that and not get locked in an argument as to whether it constitutes a syndrome or not. And I think I heard Dr. Haley really moving forward saying we need to work to say how do we recognize unique constellations of symptoms that may help us in treating veterans. We had a lot of dogma saying, there's no increased rate of diseases. But when you look at 700,000 people, you do get a lot of dilution. And so it really is important to take a look at individuals and locations. The findings of ALS were certainly a new finding, and as we've heard repeatedly and from Secretary McKay this morning, that in fact the study's not published, but we're taking action, the VA has taken action on recognizing that this may be related to service in the Gulf. How? Again, science doesn't understand that. We don't know what the cause of ALS is in the great majority of people. We've looked at hospitalizations in DOD and VA. We've looked at deaths. And again, it's how precise are you using the information? What sort of causes of death are you looking at? And again, we're not seeing major differences. The mortality from automobile accidents was seen early on. Looking at it now 10 years later, it does not appear to be statistically significant recently. We don't understand the explanations for that, but I think that's where research needs to focus. Birth defects, We talked yesterday, you talked yesterday about the self-reported. Again, we need to keep our minds open and relook at these issues as we move forward. The bottom line is, what is the cause? And that's hard. That's where science comes in. And science is so slow. I mean, science has not found a cure for cancer, but we have a lot of treatments out there. I think for Gulf War veterans, we need to start focusing on, rather than what's the cause, is how do we move to treatments for individuals? We may back into the cause by looking at treatments. And I think that these are some issues that I'd like to talk with you about a little bit more. I recently attended a conference of the American College of Physicians. These are internal medicine specialists who credo is evidence-based medicine. If it's not been proved by rigorous science, then we don't hold on to that as pure truth. I think what impressed me is a presentation by Dr. Daniel Claw, who currently at the University of Michigan School of Medicine, formerly was at Georgetown. And he talked about symptom syndromes, one or many. There were 5,000 internists at this meeting. 1,000 of them came to this session. So this is clearly an issue in medicine in the United States. And many of these physicians present are from around the world. And I think looking at chronic multi-symptom illnesses is perhaps another way to say, where are we going with trying to understand the complex of symptoms that we see in individual patients. I think it certainly is an approach to start. And as you see here, Dr. Claw is saying there's a great deal of similarity in these symptoms. He happens to be a rheumatologist, so he makes a lot of diagnosis of fibromyalgia. He has colleagues who are psychologists or psychiatrists, and they tend to make more diagnoses of chronic fatigue. It's the same patients, but it depends on which specialty you come to see. I listened to a briefing by a gastroenterologist who had a lot of patients with irritable bowel syndrome, and yet when they describe the symptom complexes, they're very much alike. Go to the next slide, because this is where it got exciting in Dr. Claw's presentation. He believes that this certainly is a central nervous system issue. Again, remembering what Dr. Haley said yesterday. Chronic pain, if you take that as one of the symptoms that is present in many of these individuals, it's like the volume on a TV being set too high. And they experience pain where other people who don't have that complex of symptoms don't. It's extremely important that the physicians validate the patient's symptoms. We've heard before, well, it's the patient reported. As a physician, all of the symptoms of patients come to me are patient reported. So symptoms need to be managed. Perhaps they can't be cured, but how do we work to manage the symptoms? And then wellness and function need to be the focus rather than illness and pain. And that's very important to how do we move to that next step. The physicians and the patients have to work in a partnership. And having spent about 3 to 4 years talking to military physicians with Gulf War veterans, that partnership did not exist. It was not something that was recognized as an important issue in military medicine. Next slide. This to me, I think, was really important. When you take a look at effective treatments, exercise in Dr. Claw's presentation is being looked at as having an effect like a drug on the central nervous system. If you look at people who are real exercise freaks, they talk about the endorphin high they get. Well, exercise does work like a drug on the central nervous system. Cognitive behavioral feedback does put the patient in control of working with the symptom complexes. And then pharmacological interventions where it's necessary. Dr. Claw showed some pictures of SPECT scans of brains, and you have a patient with fibromyalgia with his diagnosis. Put 4 pounds of pressure on their thumb, which is a pain point, and they get a part of their brain lights up. You put the same 4 pounds of pressure on a person that doesn't have a diagnosis, nothing changes in the brain. But if you increase the pressure to the point where they perceive pain, that same area of the brain lights up. So again, this focuses a central nervous system issue in patients with these multi-symptom complexes. Next slide. I think there's clearly a debate over Gulf War veterans in medicine. For you yourselves, there's no debate. Gulf War veterans are ill. I believe it's important to recognize, though, that this debate in medicine is part of what the science of medicine is all about. And there are quandaries like this in medicine and science. So I'd like to talk a little bit now about hormone replacement therapy. This had been one of the truths in medicine, that giving postmenopausal women essentially estrogen to ease the hot flashes and the night sweats, that they found women had a decrease in heart disease, a decrease in Alzheimer's, certainly fewer broken bones from osteoporosis, less severe depression, and less urinary incontinence. And that's what medicine believed, and that's why many, many women were given estrogen replacement therapy, not only for the symptoms of menopause, but for all the good benefits that happen subsequent to that. We've had similar observational studies done looking at people who smoke tobacco products or live in areas of air pollution and comparing them with populations who don't smoke or live away from air pollution. The medical science has determined that smoking leads to cancer and heart disease, and that air pollution is dangerous to your health. Those are observational studies. Estrogen clearly, as the slide shows, eases hot flashes and night sweats. And the observational studies are what you see on the slide. But in the last few years, medical science has done the random controlled studies, assigning women to one group of estrogen or to a placebo effect. And if, in fact, all the things on the slide you see below did not occur in those randomized controlled studies. Next slide. When they took a look at the women in the observational studies, what they found out was those women who chose to take hormone replacement therapy and continued to take it, as compared to the women who chose not to take hormone replacement therapy or didn't continue to take it, the women were thinner, they ate healthier diets, they were less likely to smoke or drink, and they're more likely to exercise. And so those lifestyles led to a decrease in heart disease, and certainly a decrease in osteoporosis and broken bones, and those findings. So I think that it's extremely important, as individuals who are concerned about health, that you recognize, as we look at data, perhaps from a different perspective, you get a very different conclusion. I think chronic multi-symptom illnesses are a recent addition to the public health scene. And I think researchers in many centers are working to address these concerns. And it isn't just the researchers. Just look at what's on TV. Products recommending you take for memory loss or for fatigue, for muscle or joint pain, for difficulty sleeping, bloating, and gas. These products are being marketed because patients are having the problems. I'm really hopeful today that today's research will lead to a better understanding of the causes of these chronic multi-symptom illnesses and provide insights on prevention and effective therapies. Next slide. I'd like to shift now to talk a little bit about forced self-protection. Steve Robinson kind of opened your session talking about forced self-protection, that in fact so many people in the military who should be responsible for this don't even understand what it is. And so I will agree that this is a concept. This is not something that is 100% working in military today. And that's the goal and the focus of deployment health support, is to make this more than a concept. It begins with pre-deployment. And this essentially is a concept that allows operational leaders to put forced self-protection into their operational plans. For the military member, it begins with coming into the service, getting that induction physical, getting the vaccines to bring a person up to date, getting into the exercise programs and the health as far as diet, smoking cessation. In this process, we included the annual dental examinations, and then prior to deployment, there should be a health assessment questionnaire. This is not a complete health checkup, but it should be one that allows a service member to bring any health concern or problem to the attention of medical people so that they can be dealt with on an individual basis, so that we deploy people who are physically fit, ready to go, and those people who have medical problems are not put in harm's way inappropriately. There should be briefings on what the medical threats are, both in the environment, the endemic diseases, what's in the area that people are being assigned to, and in a peacekeeping role, if that's what the assignment is. There should be industrial and occupational surveillance before troops are put on the ground, and that should continue while troops are there. There should be monitoring of what are disease rates and symptoms that are being seen in the deployed people for early signs of an epidemic of an infectious disease or some other environmental pollutant. And then when people come back, it's extremely important that they get a debriefing on what was it that was in the environment, if they have questions to what they saw, smelled, tasted, that there are explanations provided to them at that time. The post-deployment questionnaire should again be a ticket to getting people the kind of medical attention that they need. It should not be one size fits all. And if people have pulmonary problems, they should really get that evaluation and be seen by people with expertise in that area to make sure that that system or whatever the complaint is fully addressed and medically evaluated. And again, it should be a two-way communication between the military people who are deployed and the healthcare system that's there to support them. I'm sure Dr. Engel was going to talk a little bit about the post-deployment clinical practice guideline, and Secretary McKay touched on that. DOD and VA have worked hard to develop a process where if people coming back after deployment come in for any medical issue, that the primary care provider will say, are your concerns today related to a deployment? Do you believe that they are? If that answer is yes or maybe, then there needs to be focus on what is it that makes you believe that, what are the symptoms, how do we work to provide information and answer that concern. And I think that this will only be successful if the medical community understands it and the patient community understands it. That service member needs to know the system is there to support them. They have to be the one to say, I have a question or I have a concern. In the civilian world, people go into their doctor with all kinds of things off the internet and say, what do you know about this? In military medicine, we need to kind of open and embrace that approach. This is the right way to take care of people and answer their concerns. Next slide.